Welcome dear students and physicians. Here today we will learn about the history taking in the clinical medicine. Again welcome all. I am Dr. Ravi Kumar Sharma, pulmonologist and critical care consultant currently working here at Bhopal, India. So let's start and begin the practice of good history taking. So here the question arises, why to practice good history taking? In clinical medicine, our main job, our main work while history taking is to find out what is the probable diagnosis that is bothering the patient complaint. So the simple answer is just listen the patient patiently. He or she is telling you the diagnosis. So taking a careful history and precise history will give you the diagnosis, and that will help us to treat the patient better. So proceeding further, we have to again emphasize the patient particulars and demographic details. Every point in the patient particulars and demographic detail is very important, like name, age, sex, religion, ward where the patient is admitted, bed number also, and hospital case sheet, health ID number, whatever is applicable as per institute. Address is for follow-up calls, follow-up visit, follow-up reminders, contact number for the same to contact the patient in the future. Identity card number, sometimes especially in the medical legal cases where it is very important that identity card number should be collected and it should be with the patient file. Now comes the first point is chief complaint. Chief complaint means it is a major complaint with the duration that should be written in the patient's own language in chronological order of their appearance. What does it mean? It is a major complaint by the patient and that should be written in the patient's own language and in the chronology order of their appearance. So just to split this word, we can have their typical feature of chief complaint should have the following points, like the reason to be in the hospital. For example, the patient may have 3 or 4 different symptoms, 3 or 4 different complaints he may have, or he may have some ill health, some chronic illness, some long-standing problem, long-standing disease he or she may have suffering from in the past. But what is the present complaint, present symptom that has led the patient to come to the hospital? So the reason to be in the hospital is a chief complaint. And the maximum chief complaint should be 2 to 3. It should not be more than that. Sometimes the patient will say, I have headache, I have myalgia, I have joint pain also, I am having fever on and off. So that doesn't make a chief complaint. Chief complaint is a very precise. It is the reason to be in the hospital. Yes, the patient may have many complaints, but what is the important that chief complaint that patient has to visit the hospital? And yes, it should be with the duration in chronology with timeline. It should be with the duration in chronology and as per timeline. For example, we can see here a typical example. The patient is having fever for 3 days, rash for 2 days. Here, say one patient, a 60-year-old lady who is a diabetic, hypertensive, having osteoarthritis for the pretty long time, and she will come to the hospital and will say, doctor, I have joint pains, multiple joint swellings, I have fever on and off, and some rashes just I appeared 2 days back, I have sometimes headache also. So this kind of things, this kind of symptoms are very vague. So in that situation, we have to be very sure, very clear that yes, the patient may have these problems for the pretty long time, but what is the actual, what is the real reason, real symptom, real bothersome symptom the patient is having, so that she has to visit the hospital. So she will say, this doctor, I have fever for 3 days, and just I am noting, I can see some rashes on my hand for the last 2 days. So this will be her chief complaint. Now coming to another point, next is the history of present illness. So we have understood chief complaint, and the second is the history of present illness. History of present illness is simply, it is a description and elaboration of chief complaint with idea to extract as much information about patient complaint from patients or relatives in his or her own language. What does it mean? History of present illness is just unfolding, elaborating the chief complaint the patient is having at the time of presentation, and that is actually elongated, that is unfolded, and that is description that we describe in the history of pain illness symptom by symptom. And here we do not have to interrupt in the patient's story. So let the patient to tell their story. They are telling you the diagnosis. It means in history of pain illness, we have to allow the time for the patient to just explain themselves, what's wrong with them, and just listen patiently. And what they are telling their disease, and they will, by just giving them proper time to describe their symptoms, they will tell you the diagnosis in some time, because of some classical typical history of some diseases are present. So what does we do in history of pain illness? It is a expansion of chief complaint in relation to their mode of onset. It is acute, subacute, insidious. The progression of the symptoms, it is progressive, static, or with exacerbation and remissions, and duration also. Progress during stay in the hospital should also be inquired to. If some symptoms is having persistent, intermittent, and it is there for a pretty long time, their progression during hospital should also be inquired. There should be positive plus important negative points about the presenting symptoms. Positive points are those points which is going to favor the diagnosis. Negative points are those points which are against the diagnosis. For example, a patient like paralysis in the neurological disorder or breathlessness in cardiovascular disorder, this is a positive signs or positive point actually. So let's see here one example. A patient who is coming with a chest pain. So chest pain left sided, and patient is telling that what is the positive point in favor of that chest pain could be of respiratory origin is this, that patient is having chest pain, expectoration, cough, and fever. So that goes in favor of that patient has some problem with the respiratory symptoms. Maybe he is having some pneumonias. But if the same left side chest pain is a central over the precordium associated with palpitations, sweating, radiating to the left upper arm, and sometime the patient will say, yes, doctor, I can feel my heartbeat in my chest wall, chest cavity. So that gives some idea that yes, this patient might have some problem. Seems like that the patient is having some problem with his heart or the cardiovascular system. So these are the positive plus important negative points. So always we have to make a note that what the symptoms are in the favor or in the against to a particular diagnosis. Whenever the patient starts telling his chief complaint, he starts expanding his symptoms, like in history of illness, the way the patient starts saying his story, our mind works on the differentials, because our main job is to find out the differential diagnosis of the patient presenting symptoms. So as soon as the patient starts telling their story, our mind in the subconscious or conscious mind starts to figure out, yes, what could be the differentials. So that is the job of a physician. So in this way, we have to interrogate, we have to explain, we have to elaborate the symptoms in history of pain illness. Here, use patient's own word and avoid scientific or medical terms as far as possible. Like joint pain is preferable term than arthritis. So history of present illness means here give the patient own time, and they should describe their symptoms in their own words, and we should not prompt them to use scientific words. Do not put leading questions suggesting their own answer. For example, we should not tell them that yes, do you have a fever with that symptoms, or do you feel chest pain? So sometimes patient will say, it's kind of leading question. Patient will say, yes, doctor, sometimes I have fever. Yeah, sometimes I have arthritis, sometimes joint pain also. So don't put leading questions. Sometimes some direct relevant questions, if we think that by doing this exercise up to this point, if the patient is saying, yes, I am chest pain, sometimes palpitation also, and if I think that history is suggestive of some cardiovascular problems, so I can ask, do you have shortness of breath, or do you have effort angina, do you feel heaviness in your chest while walking? So these kind of questions, it's depending on the patient complaints, patient history. This will help us to narrow down our differentiation and to focus on our diagnosis. So in some situation we can use this one. And also record relevant associated symptoms. Associated symptoms means one is the primary symptoms for which the patient has attended the hospital, plus what are the associated symptoms with your current problem, that also we should look for. and some generalities like how is his appetite, has there been any loss of weight, do you feel fatigue, what is about sleep pattern, how is your bladder and bowel functions are there. So that generalities should always be asked for. Sometimes bowel and bladder habits, it should be included detail in the personal history. I personally suggest that bowel, bladder, sleep, appetite, this should be have a proper space and this should be elaborated when we discuss about the personal history. So to sum up, in history of present illness, there should be maximum 3-4 paragraphs. Paragraph 1 for expansion of chief complaints, and that is based on the chief complaint. This para may be subdivided into para 1A, para 1B. For example, we have seen there a patient having fever and rash. So paragraph 1A, expansion of fever for 3 days. Paragraph 1B for description of rash, how did it started, when did it started, has it been progress or not. So that is detail about second symptoms. Paragraph 2, important positive and negative findings we have to mention here, and about general issues and health, for example like weight loss, any major generalities like fatigue, sleep, and what about the bowel bladder habits are there. So by this time we can have a brief idea about the chief complaint and history of present illness, and from here we can have some idea that which system, which organ system is at fault or which is creating the problem for the patient. What we do from the chief complaint, from history of present illness, we try to figure out which system is at fault or which system is not working properly, that is giving rise to these symptoms. So our job is to proper history taking is to figure out, to reach out the diagnosis, and accordingly we have to do the investigation, relevant investigation to reach the diagnosis. So by this time we will sum up this lecture or some of this discussion only here. In the next part 2 we will discuss some detail about from the past medical history onwards and to the other points. By this time we only want to focus on these 3 important things, that is patient particulars, chief complaint, we have studied chief complaint, and history of present illness. Okay, thank you so much. We will meet in the next part 2 video of this history taking. And just if you have any comment, you have any suggestion, just put in the comment box. Thank you.